Welcome to a very special Reach Out, Reach For webinar, for which we are filming live. It's our first live webinar from Dundee, and we are joined by the amazing Tom Gilbertson, who is sat to my, well, technically my right, but it might be my left on screen, who knows. So for those that don't know you, Tom, can I ask you just to introduce yourself, please?
Well, thank you. Yeah, I am a neurology consultant based in Tayside, and I'm also a senior lecturer in neurology at the University of Dundee. And I have the role, my clinical role is kind of lead for dystonia in
Brilliant. I mean, we can't wait to get to the questions, and thank you everybody for asking so many questions. So, Tom, we've had a number of questions about focal dystonia. Before we get into those, could you just explain what a focal dystonia is?
So, yeah, I was immediately worried you would ask this question because it immediately comes with a certain degree of baggage.
Okay.
So, neurologists mean sort of two different things when they talk about focal dystonia. So, you could have focal dystonia as a symptom in a condition like Parkinson's disease, but it can also be a syndrome in sense of a primary form of focal dystonia.
Right. And
traditionally, we view primary forms of focal dystonia, like cervical dystonia, as a movement disorder, and its primary features, if you like, are characterised by abnormal posturing and involuntary movements with varying degrees of symptoms like venom and pain. But I think the key thing with primary focal dystonia syndromes is that they're really not uniquely limited to disorders of movement. So we see other symptoms which are kind of classified really as non-motor symptoms, which really make this a much more complex problem than just a disorder of movement.
Thank you.
I think that answers any question at all.
No, it absolutely answers the question. We like going straight in with the tough questions here at Dystonia UK. So the first question that we'll start with is, could a musician who describes their finger as jumping by itself potentially have a focal dystonia?
Yeah, I mean, obviously, without taking a history from that musician, it would be difficult to be certain, but certainly in musicians who are practicing a lot, they don't have to be professional musicians, but yeah, that symptom could easily be the beginning of an early form of focal musician. As an occupational hazard of where we practice, we get patients with piping dystonia, so bagpipe dystonia, and generally that happens in patients who are often performed at a very high level. So it's unusual to see vocal musicians with dystonia in people who are playing at an amateur level. So if they're playing at an amateur level, that would be less likely to be a form of vocal dystonia in terms of musicians with dystonia. And again, the reason for vocal dystonia emerging in musicians is unclear, but it requires a significant amount of over practice and hundreds of thousands of hours of practicing before that dystonia emerges.
When you said piping dystonia, it just took my brain half a second to remember that.
I thought I'd throw that in.
No, it's great.
I thought we should have a Scottish.
I like the Scottish reference, absolutely. It just took me a half a second to work out what you were talking about there. So, can people recover from a focal dystonia?
So this is a very good question. The answer is very, very rarely they can. The most common scenario is if you take focal cervical dystonia that affects the group of patients will develop remission. So about 1 in 10, and a subgroup of those potentially can have permanent remission, but the vast majority of people will have persistent symptoms. So the answer to that question is it's very, very unusual, but it's not impossible. And the vast majority of patients who are diagnosed with, say, focal cervical dystonia will have that for the rest of their life. So it will vary, obviously, with degrees in terms of the intensity of the symptoms, but it's, I think, broadly speaking, when you make that diagnosis in clinic, you'll make a diagnosis for life.
Okay. So it's possible, but not.
Incredibly unusual. And
Okay.
look, certainly the patients that I have, I haven't met anybody who's had complete permanent remission from a form of disturbance. So I'm yet to meet someone who has had that, that occur. So it is unfortunately a chronic illness, and I think that is probably not surprising given the likely kind of underlying changes that happen in the brain in dystonia patients. It's unlikely that those changes, even if we say for the sake of argument that we're not that sure about what causes them, are likely to rewire, if you like, and revert back to normal. I think that they are on permanent.
You were speaking about in focal dystonias that remission is possible through rewiring the connections. Is that possible without medical intervention, i.e. without botox or without DBS?
The answer to that is no. Certainly on the basis of present evidence that we've got in terms of other forms of treatment. So, for example, you would kind of think that why, if you approach a patient with focal cervical dystonia, for example, why if you gave them lots of physiotherapy to kind of retrain the kind of head muscle control, why wouldn't that improve their symptoms? And the answer is we don't know, but we know that it doesn't improve their symptoms. So physiotherapy and kind of brain retraining approaches in their current form don't appear to improve the symptoms. And I think that probably it gets to the crux of the issue, and that is we don't really understand beyond the very superficial level what really happens at the deep kind of neural connection level in these patients. So we don't really know what sort of strategy we need to take to approach that rewiring. I'd love to be able to say to my patients, right, let's get rid of Botox and let's retrain the kind of nervous system or the neural circuits that have gone haywire here in dystonia, but we don't know what they are. We don't really understand the intricacy of the problem beyond that superficial level, and so we don't really have an intervention that's that clever at this point to actually do that.
So Botox, DBS still the current way forward?
Well, the current interventions that have good evidence that they work, and I'm sure patients are probably sick of doctors going on about evidence-based medicine, but the thing is we want to give patients treatments that we know that work. And the conventional way of knowing whether something works is to design a very complicated study, a trial, where you compare a treatment versus a placebo treatment and measure whether that intervention is effective or not. And that's the kind of gold standard. And we know that with Botox that does in fact work. We know that with DBS it works as well. So those are currently the treatments with the strongest evidence base. That's not to say that there aren't other treatments out there, but we need to study and construct and fund ultimately the research that can answer those questions. And sadly, most of these trials, even if they're designed and funded, don't necessarily get the answer. Often they'll be completely null results, and we don't see a significant.
That must be frustrating.
Well, I think it's part of the process of clinical trial development, and unfortunately, it's not unique to dystonia. It's likely to be a feature of every condition that we try and treat, whether it's dystonia or not.
Okay. So moving slightly on, do you know of any correlation between goiter and dystonia? Is a question we've been asked.
So that's, it's an interesting question. Obviously, you think if you have a goiter, would that in some way kind of mechanically change the way that the musculature might work in dystonia? But we know that dystonia is not driven by any peripheral muscular problem. It's driven by those abnormal signals that we've already talked about, and the abnormal posturing that results from those brain signals, if you like. And someone who's got a goiter, it's very unlikely the goiter is driving the dystonia, with the one caveat that certainly if you've got uncontrolled hyperthyroidism, so if your thyroid is pumping out lots of thyroxine, then that will generally make everything worse, and that includes your dystonia. So it might be a coincidental thing if the if your thyroid function is poorly fully controlled, then that might lead to worsening in terms of your dystonic symptoms. But I wouldn't say going to cause dystonia in a direct sense.
And just in case anybody doesn't know, other than the person that asked the question, can you just explain what goiter
is an enlargement of the thyroid gland. So the
Okay.
thyroid gland sits in the neck there, and it pumps out thyroxine. And if you have an enlarged thyroid gland, then it creates too much thyroxine,
Right.
and that can often worsen neurological symptoms in a very general sense. They're not specific to dystonia, but if, for example, if you have somebody with Parkinson's disease or any other symptom, if their thyroid function is out of kilter, then it can worsen their neurological symptoms.
I suppose that would be like almost if any part of your body was not working correctly, it could impact another condition.
But I don't, there isn't a, if you like, a causal relationship between thyroid function and cervical dystonia, for example. So you could have lots of people with thyroid function with cervical dystonia, and you wouldn't find any relationship in terms of their development of cervical dystonia and their thyroid dysfunction.
Okay, thank you. So our next question comes from someone with myoclonic dystonia with the DYT11 gene, and that's worsened over the last roughly 3 years, and they're no longer under the care of their original neurologist as they live in a different area. Can they be referred to a neurologist who specialises in dystonia, and do you know how they'd go about that?
Well, I can, from our local process for that would be that they would go back to their GP, and their GP would very easily refer them back to the neurology department, their local neurology department. And generally, neurologists have different interests or specialist interests, and the likelihood is they'd be seen by a movement disorders specialist, and that referral will be directed to a movement disorders specialist for them to be reassessed. But it sounds like a very reasonable question to ask their GP to initiate that referral. Back
to the GP, get the referral, movement specialist. Then brilliant. Thank you very much. So our next question, I love it when people, the wonderful Vic puts in questions I can't pronounce. Can dystonia be caused by, this will be interesting,
haloperidol?
Thank you so much. Thank you for not just letting me struggle with not knowing how to pronounce that. The word you just said, depot injections, used for someone with Asperger's. Right. I'm so sorry, everyone, if I butchered that pronunciation.
So this is a really interesting question, and the answer to that is not straightforward, actually, because what we know is that, broadly speaking, dystonia of focal type or even generalized form of dystonia, we know that there's something going wrong with the way that the transmission of dopamine neurotransmission deep within the part of the brain that controls movement. And that's been recognized for a very long time in dystonia. Now, haloperidol is a drug which blocks dopamine transmission. And so certainly there's quite a good rationale for thinking that haloperidol might worsen somebody with, say, cervical dystonia, because it might block or exacerbate that dopaminergic problem. The question of whether it can cause dystonia is really quite challenging, because the issue there is that potentially there are certain underlying factors or vulnerabilities in that individual. Let's say they may have a genetic vulnerability, and it's the drug, if you like, that then precipitates the manifestation of dystonia. So it kind of unmasks that vulnerability. And it's a very controversial area as to whether these atypical or typical antipsychotics actually can induce other forms of dystonia or not. One of the problems is that patients who were studied with schizophrenia in the 60s, well before the advent of things like haloperidol, actually developed forms of focal dystonia later on in their disease course. So it's clear that these drugs can potentially precipitate and may have a causal element to the development of focal forms of drug-induced or tardive dystonia is the kind of term. but their absolute causal relationship is actually found in a bit of mystery.
Okay.
Sorry, it's a very long-winded answer, but it's actually a really difficult question to be certain about. What I would generally say is that if you've been on haloperidol and you've developed dystonia, and the overall severity of dystonia warrants potentially stopping the haloperidol and considering an alternative medication for the Asperger's, then that would be a pretty standard thing to do. But that would have to be a decision with the patient's psychiatrist as to whether the risk of stopping it outweighs the benefits. But yeah, and the challenge there is that sometimes by stopping the antipsychotic, you don't always get the movement disorder doesn't always go away, so it can often persist despite the removal of a drug precipitant. Which again kind of goes back to the question of whether it's unmasked the problem. You'd expect if it was causing the problem, if you got rid of the causal agent, maybe it would just go away. Yeah. So yeah, so it's a tricky one, that, and I've been down that route several times before with other patients where actually this drug is probably driving a lot of the dystonia, and the dystonia is severe, but actually if you withdraw that drug that's managing their psychiatric symptoms well, then you can actually make things a lot worse. So it's a very challenging problem, Matt, and it needs very close coordination between the neurologist and the psychiatrist as to what the right course is to go down.
Yeah, joined up care, isn't it? So these questions kind of follow on from everything you've just said, and you might not be able to be concerned about these either. But we've had some questions around specific drugs and their effects. So I'm just gonna name 3, and again, people, I apologise if I don't know how to pronounce it, but there's an atypical antipsychotic.
Aripiprazole.
Thank you. You are
great. No, I'm just mind reading.
I have the questions written down.
Yeah.
And Tom knows all of them.
Yeah. So it actually goes back to part of the answer of the last question. And aripiprazole was developed by drug companies to reduce the risk of drug-induced forms of dystonia. Right. And the idea is that it in principle has a lower risk of that, but that risk is not zero. Actually, I think that most psychiatrists and neurologists would acknowledge that there is still a risk of drug-related dystonia with aripiprazole, because again, its mechanism of action is closely related to that dopamine circuitry that we were talking about before.
So the other 2 are paroxetine and mirtazapine.
Yeah, the party line would be that there wouldn't be a strong relationship between either of those. Now the challenge is if you were to go onto Google, you could probably find lots of case reports associating antidepressant use with secondary development of dystonia, and that's quite difficult. Again, it goes back to the earlier discussion about kind of evidence of causality. Now, if we studied 10,000 patients on mirtazapine and 10,000 patients on a placebo, and the incidence of cervical dystonia was significantly greater in the mirtazapine group, then we could be sure that there was a definite relationship. And we don't have that information, and I don't think that study will ever be designed for lots of different reasons. But the important thing about cervical dystonia or focal forms of dystonia is actually it's very, very important to treat any underlying mood or anxiety disorder that's comorbid with the movement disorder, because these problems really feed into one another. So when people have very low mood or very high levels of anxiety, their dystonia is a lot worse. Their symptoms are a lot more intense. And the relationship between mood and anxiety and dystonia is actually deeply interesting, because we know that this isn't just a secondary consequence of living with a chronic disease. The incidence of mood and anxiety disorder in patients with focal dystonia is much, much higher than you'd expect for living with any other chronic disease.
Okay.
And that tells us that potentially the same, if you like, chemical messengers, the same pathways that potentially contribute to the movement disorder are also overlapping with the psychiatric symptoms. So it goes back to the very first question when we talk about the primary focal dystonia as a syndrome. It's much more than a mood disorder. It's actually the non-motor syndrome really is actually quite a complex neuropsychiatric condition. So I tend to encourage all of my patients who have got, who have got a history of depression or anxiety and have got symptoms that need to be addressed, that they should stay on and carry on being medicated for that, whether it's with tazapine or paroxetine. So I don't think in their case I would necessarily attribute the dystonia to being causally related to the antidepressants.
You mentioned mood there and being low. So can stressing increase dystonic symptoms?
Yeah, the problem is, what is stress? And
that is a question.
And I'm asking you that question.
Oh, well,
it's a rhetorical question. The problem is, so stress is really interesting, and we obviously feel stress on lots of different levels. You can feel that acute sense of stress when you feel panic, and then there's that more kind of insidious sense of stress that you don't really have very much insight into. And I think the answer is that both forms of stress can exacerbate the chronic symptoms. Now, is stress equal to anxiety and depression? I'm not sure sometimes. I think sometimes you can be stressed and under pressure, and that's just part of life's kind of the laundry that we all have to, kind of life laundry to work, and you don't necessarily have much in the way of mood or anxiety disorder, but addressing those stressors is really important to managing the other symptoms of dystonia. So it's, I think you're absolutely right. I think dystonia and stress kind of, they feed off of one another. For sure. Yeah.
We get told a lot, stress, anxiety, it makes the symptoms worse. That's something that we hear, and every time we've done a Q&A, actually this has come up. So it's clearly on the mind of the community. So next question is, how common is tardive hemidystonia, and where would someone find research?
Tardive hemidystonia. So we've talked about tardive dystonia. Tardive dystonia generally affects the neck and the eyes and the mouth. Or tardive dyskinesia is where there's extra kind of involuntary movements around the face and tongue. I've never seen tardive hemidystonia.
Okay.
So the answer to that question is that I'm sure it's possible, but whenever somebody's got dystonia down one side, particularly if it's coming on later in life, then we want to make sure there's no structural reason on the other side of the brain that might be causing that dystonia. So I certainly, in a patient with hemidystonia, I would be keen to have a look inside the brain with scans just to make sure that things are okay. But a tardive form of hemidystonia, I haven't seen. That doesn't mean it can't exist, but it would be, in my experience, a bit of an outlier of the normal expression of tardive dystonia.
Okay, thank you. And this is the last question before we're going to move on to the newly diagnosed section of our Q&A. And it's been prompting quite a lot of chat.
All right.
So here we go. Is dystonia the same as FND? And for those that don't know, could you just explain briefly FND?
I just had a feeling this question was going to come up. I mean, it's a really tough question. So the answer to the question is FND the same as or focal dystonia? The answer is no. They are two completely different diagnoses.
Okay.
The problem is that we see patients with functional forms of dystonia. So, and they can look certainly to even a trained eye very, very similar, and it's a very difficult diagnostic process trying to tease out whether somebody has a functional form of dystonia and somebody who's got an organic, but a primary form of dystonia. Okay, and sometimes we see a mixture of both. Okay. Sometimes you can see people who've got a primary form of focal dystonia and they've got functional overlay. Okay, so they've got functional symptoms on top of that. And if you like, the kind of distinction is this. So with primary forms of focal dystonia, we think about the hardware of the brain going wrong, so those chemicals that we're talking about, we know that the structure of the brain is normal, so you can put as many people with primary focal dystonia through an MRI scanner and their brain structure is normal.
Okay.
But the, if you like, the physiology of the circuit is wrong, and that reflects an intrinsic hardware problem. Whereas with functional problems or functional forms of dystonia, actually the problem lies at an even higher level, if you like, on the, if you like, the software that the brain is using to control movement. And the ultimately the difference between the two, it doesn't really matter a huge amount other than the underlying etiology of the two conditions. Both of them generally are chronic. Some patients with functional dystonia will actually are more likely to see remission than people with primary forms of focal dystonia. Generally, neurologists won't treat functional forms of dystonia with botox, but occasionally we do. But it's a very much a decision on a case-by-case basis.
Okay, brilliant. Thank you. I mean, thank you for answering all those on focal dystonia. We had a lot of questions. So I'm conscious of time, and we want to get to all of the questions that we can. So we're going to whiz through a couple of them, but these specific questions, just to set the theme for you a little bit, come from someone who is newly diagnosed with dystonia, who has it in their left shoulder, upper arm, wrist, and hand. And you may not be able to answer these questions, and that's okay. Without meeting the individual, but perhaps you could speak generally to the answers, as I'm sure these are common questions and concerns. So the first would be, what advice would you give to someone who is struggling to accept their diagnosis of dystonia?
I mean, I think the most important thing, if they were my patient, is I'd probably be spending some time talking to them and understanding what aspects of the diagnosis they were struggling to come to terms with. I think if they're questioning the diagnosis, I think they need to have a frank conversation with their neurologist and say, I don't understand X, Y, and Z. And most movement disorders neurologists will be able to say, look, it's this because of X, Y, and Z, and actually this is where we are with this. And so I think it's important when there's any uncertainty about accepting the diagnosis to have a complete transparent dialogue about the reasons for not being able to accept it.
Okay, so talk to your neurologist.
I think so.
In depth. Excellent. Can dystonia spread?
Yeah, so the answer to that question is some forms of dystonia are more likely to spread than others. And again, don't really know why this is, but people with forms of ocular and ocular sort of pharyngeal, so dystonia affects the swallowing and speech. That can spread a little bit quicker, so sometimes it can spread into the neck. It's unusual for it to spread much further than that. Occasionally you can meet people who've got spread in a segmental way into other, even into the limb. Patients with cervical dystonia, it's very uncommon to see that spread, but it can spread often over a decade, and occasionally you can see people who might go from having focal cervical dystonia to, say, ocular, so blepharospasm. So the faster spreading ones are ocular forms of dystonia, and the slower spreading ones are generally with cervical forms of dystonia. But actually, for the vast majority of people, the dystonia often remains quite fixed over many, many years, and it doesn't really spread. And I don't know why that is. I don't think we've got a good handle on why some people are spreading and some people aren't. Yeah.
Okay, brilliant. I would imagine this will be quite a quick answer. Can people work with dystonia?
Yeah, I mean, we're talking about broad church here.
Yes, absolutely.
So certainly, and it's interesting. It obviously depends on the severity and where the dystonia is. So some of my most disabled patients have got blepharospasm, and they are functionally blind because the blepharospasm is so severe. So they can't work in any meaningful way. But for a lot of patients with other forms of focal dystonia, their work is entirely compatible with their condition. But obviously, it's about being realistic and setting kind of reasonable goals about what you can do and what you can achieve, because as we've already alluded, the kind of that stress and that effect of fatigue in particular, I think, will often exacerbate symptoms. So knowing, pacing yourself in terms of what you're doing day to day at work is quite important.
Awesome. And again, I think this would be quite a quick answer is, will it affect their ability to drive? So these are quite practical questions.
The answer to that is, again, it really boils down to the individual. Now, clearly, if you've got a generalised form of dystonia, then the most sensible thing to do is to get a driving assessment before you drive. And the neurologist will generally advise you if they're not sure about your safety to drive. 99% of my focal dystonia patients will drive, but again, if you're not sure about driving, you can ask your neurologist, and if your neurologist isn't sure, then we will refer people for a driving assessment. And they actually, driving assessments, occupational therapists really want to pass people, they don't want to take away licenses. So, but it's a safe thing to do, because ultimately, if you've got a neurological condition, whether it's cervical dystonia or any other, and you're involved in an accident, then there is always that risk that you can be culpable if you haven't been.
So doubly make sure.
Yeah. Absolutely.
And just the very last question, and this is something I think that worries a lot of people who are newly diagnosed, is does it, if you have it, will your family have it, will your children have it? The genetics, without getting onto a whole conversation about genetics, but is that a thing?
Yeah, so it's a really critical question, isn't it? If you've been diagnosed with this, what's the likelihood of me passing this on to my family members? And actually, the good news there is it's incredibly low. I've got families, and we've all neurologists got families in whom first degree relatives have focal forms of dystonia, but they're very, very rare. And the vast majority of people with focal dystonia have a sporadic form. So in other words, it's a kind of one-off, and the inheritability is not dominant. So that means that there isn't 100% chance of you passing on that gene, whatever that gene might be, to your siblings. There has been quite a lot of extensive study looking at whether we can identify genes in patients with focal dystonia, and actually less than 1% of people with dystonia have a gene that can be identified as causing their dystonia with focal variety. That's less true with generalised forms of childhood onset dystonia, but adult onset dystonia, it's very, very unusual to be a hereditary pattern.
Okay, thank you. I mean, those were all brilliant answers, and I think I'm always amazed at how much we get through when we do a Q&A webinar. So we're going to move on to treatments, and there are a lot of questions here. Again, apologies to everyone who sees me looking down, it's because I'm checking the questions as we go. Are there any known treatments for someone who has facial spasms and rapid tongue protrusions?
Okay, so yeah, that's interesting. So certainly we treat a lot of people with a condition called hemifacial spasm. The only thing I'd say is a kind of red flag there is tongue protrusions, and that's a little bit unusual. So with hemifacial spasm, the tongue is not involved, it's kind of a different nerve. And I think if I was that patient, I would be thinking about seeing a neurologist and trying to get a diagnosis that determine the appropriate treatment. Tongue protrusions are a little bit unusual, but they combine with hemifacial spasm. Okay, so again, go to your neurologist. I think so. I mean, I think we do see a thing called lingual dystonia, which affects the tongue on its own, but it's a very unusual combination to get hemifacial facial spasm and tongue spasm. But no, I think that needs a little bit of further thought for treatment. Okay. We've had this question on previous webinars, and it's come up again today. So let's just spend some time talking about CBD oil. In dystonia. So could CBD oil be beneficial to dystonia patients? Yeah. So this question, if I had a penny, this question comes up a lot, and it's not just in dystonia. Actually, we get this question answered. My colleagues in the epilepsy service are asked it a lot. Parkinson's patients, MS patients, and the answer is that nobody knows. To be quite frank, I don't think anyone knows whether this is effective or not. When patients ask me about it in clinic, I generally say I can't imagine it will do any harm. Okay, and the only harm I suppose that can come from it is that if you're using your own personal finances to kind of fund something which ultimately may not be doing anything at all. Okay, and I have had patients who have gone online and bought medicinal forms of cannabinoids and spend a lot of money, and they don't really know what they're buying. They have no idea whether this is. And again, it goes back to that earlier discussion. We don't know that there is any evidence this does anything at all. I totally agree. If I was a patient with dystonia, I would be thinking, why not try it? Yeah. It makes a lot of sense. But I think you've got to go in with an open mind about whether it's going to do anything and whether it's really worth the financial outlay. And for a lot of my patients who have tried it, generally, it's a trial without something which they do a sustained thing. Yeah. But it's out there. If someone wants to do a clinical trial, they can try. But
I imagine it will happen at some point.
Well, I don't know. I think it's a difficult one to get funding, and these things cost a lot of money to.
Okay, and I mean, you mentioned one of the cons being financial.
Yeah.
Are there any other cons you can think of, or any other pros for people trying it?
I don't think. I think as long as you're realistic about the likelihood of it working, then I don't think there are any immediate cons. I mean, it's a little bit like go to see a homeopath or a reflexologist. There is nothing inherently wrong with that. I mean, in reality, it's a different approach to Western medical.
Yep.
And I think we're all open to approaching living with dystonia through different kind of therapeutic angles. But yeah, it's one of these things that I would probably go and engage with, but with an open mind, absolutely.
Okay, and are there any side effects that you know about?
I don't know. I don't think so. I again, because it's not a licensed medication.
Yeah.
It's not in my book of drugs that I can prescribe. So
no, that's perfectly reasonable.
I've got no real knowledge of it beyond what my patients have.
Okay. So moving on from that, although we do have one, somebody has asked, and I don't, given what you've just said, you may not be able to answer this one either. What are the long-term effects of addiction and/or tolerance requiring increasing dosage?
Say that question again. So
what are the long-term effects of addiction? Is it, which I am going to assume is it possible to get addicted to the oil?
You're asking the wrong man.
Yeah, no, I had a feeling.
The answer is I don't know. I mean, I don't imagine it's got addictive properties, but I don't know.
Yeah. No, it's fair, and we try and ask the questions that we're asked to ask, but it's perfectly reasonable if the answer is I'm not the person to answer that. But thank you for trying very much. Are there any sort of sticking, I guess, with that kind of thing, but not really. Are there any medical or non-invasive treatments that are worth trying to help dystonia in children? So, for example, natural supplements, physiotherapy, specialist movement.
Yeah, I mean, I'm not a paediatric neurologist, so I'm again slightly extending my remit there. It's certainly in the adult group, there isn't any good evidence that physiotherapy makes any significant improvement, but ultimately physiotherapists are extremely good at what they do, and there's very little harm if a child has got dystonia which is affecting their gait for them to see a physiotherapist, and a physiotherapist will work on aspects of their movement which ultimately are going to be positive, even if it doesn't have a kind of longitudinal effect on the overall course of their dystonia. So no, I certainly would have a low threshold and for involving a physiotherapist into anybody with generalized dystonia if they need one.
Okay, thank you very much. one more question on treatments, and then we're going to move on to Botox specifically, just so you know where we're going. Do you have any advice on treatments that help with dystonia-induced sleep disturbance?
Yeah, so I've got, so the difficulty with dystonia and sleep is that ultimately improving the neck or the neck position or the pain from the dystonia is the way forward there, right? And the treatment for that ultimately is trying to tailor the botulinum toxin approaches in an optimal way. But I acknowledge that people will get partial response to that treatment and sleep can be really profoundly disrupted. I think there are two avenues with sleep. Very occasionally, a short course of drugs like clonazepam can be helpful, but it's a very, I would use that often in a kind of extreme state where somebody's kind of having recurrent episodes of kind of insomnia to the point that actually it's the difference between them functioning and not. And certainly the problem with drugs like benzodiazepines, although they make you fall asleep, they don't give you good quality of sleep, and your brain gets used to them very quickly. And as a consequence, their effectiveness really just peters off, and your brain needs them. And although they're strictly addictive, your brain gets so used to them that actually you need them for reasons that don't actually provide symptomatic relief. So it comes with a bit of a health warning, that. I certainly do recommend some patients, if they're really not sleeping at all because of the pain, that a dose of clonazepam at night can give them some relief, but trying to avoid taking that more than half a dozen times in a month is probably the way forward there. Okay. The other angle about sleep, of course, is sometimes the sleep isn't caused by the kind of muscular, the mechanical effects or the pain there as a consequence of the dystonia, but it's actually just a symptom of anxiety. And so addressing the anxiety can actually improve the quality of sleep, because the two things are intrinsically related. And we know, as we've discussed before, that people with dystonia have much higher levels of anxiety, and so by extension, their sleep quality is often a lot worse. So it's important to think about what is it about sleep disturbance, what's actually driving it. Is it the dystonic posture of the neck, for example, and the pain, or is it other factors that haven't been addressed?
Okay, brilliant, thank you. Right, we are going to get in one, maybe two more questions. I'm going to ask you to turn slightly to face the mic, though. Just something in front. Let's have a think. We've got two questions or three questions on botulinum toxin, so we can whiz through those. So for context, this comes from a person who had symptoms of cervical dystonia for about 10 months. They didn't respond to their first botulinum toxin injection. What is the likelihood of them, if they have more, responding in a more positive way?
Yeah, it's a common problem, actually, and I often give patients a kind of an open option of returning back to try treatment again. If you imagine when we inject botulinum toxin, there is an element of error in terms of targeting. So you think you've got it in the right muscle with each treatment, and you could potentially kind of get it into a part of the muscle that's critical to the dystonic posture, and then at the next treatment it's not quite as optimal. So I often will give patients a few goes, even if the first treatment wasn't particularly successful, before we say that they're a non-responder. There are lots of things you can do. You can vary the toxin sometimes, with the type of toxin. Sometimes you can vary the muscles that you collect. The challenge is that, often that's kind of window dressing, and I think some patients, a good proportion of patients, are just very resistant to toxin, not with resistance to the toxin itself, but they have a form of cervical dystonia that just doesn't really respond to that treatment, and it really doesn't matter what you do, it's just very difficult to treat.
Okay, so try again if it doesn't work.
My own view is the door is open there to have another go, and actually after several cycles of treatment, you allow for a bit of variation between the treatments, actually you might have some good treatment response and then some partial ones with the subsequent treatment cycle.
Okay, so quick response to this one, I think, because I have two questions that we really want to get in, and I know that you've pushed for time today, so thank you for giving us your time very much. If the botox, the botulinum toxin injections stop working,
Yeah.
what can happen next? Can dystonia spread, or can it get worse?
Yeah, so we know that the botulinum toxin doesn't in any way modify the course of the disease. And we've already talked about the idea that dystonia, in theory and in practice, it can spread very slowly in a group of patients. Now, botulinum toxin does not stop that spread, at least as far as we know. No one has ever been able to design a study which can confirm that.
Yeah.
And my own gut feeling would be, because it's a symptomatic treatment and it doesn't address the actual underlying cause of the problem, is that stopping the Botox is not going to lead to further progression that would be greater than if you continued the botulinum toxin. Obviously, if you become resistant to the treatment, then there is that risk that the symptoms will kind of resurge, because you're back to kind of square one in terms of the treatment options. Okay,
brilliant. Thank you. That was a lot of questions on botulinum toxin. We get asked them a lot, so it's really handy to be able to put them to someone like yourself. Right, these are our last two questions. So the first one, and this has prompted a lot of chat on the Zoom today. I don't get to see it, but they pop up. Can alcohol make dystonia worse?
There are certain forms where it can get worse. Yeah, in the vast majority of primary forms of dystonia, it doesn't make very much difference at all.
Okay, thank you. It's good to know. And this wouldn't be a webinar during COVID pandemic times if we didn't ask this question. Are there any concerns about the COVID vaccination in people with dystonia?
There's always concerns about COVID vaccination for most patient groups, and I think it's a messaging thing, isn't it? I think naturally people who have got a neurological disorder, whether it's cervical dystonia or Parkinson's disease, are going to be anxious about a vaccination that could perhaps worsen their symptoms, albeit transiently. Now, everyone who's had this vaccine feels pretty variably unwell after it, so it would be unsurprising for patients with cervical dystonia for their dystonia to feel worse after it. Now, there is absolutely no evidence that that is a permanent worsening, and certainly there is no immediate concern that having the vaccine is going to worsen or speed the progression of your dystonia. What is fairly certain is if you get COVID and you get it severely, it's a really horrible thing. So, no, I recommend all my patients to have the vaccine.
Okay, that's very, very good to know. Thank you. So that's it for today.
Wow.
Thank you to everybody that sent in questions. Sadly, we've run out of time to ask anymore, but please don't worry. We saved them and endeavour to get answers for those in due course where we can. All that's really left to say is thank you to you, Tom. You've been amazing. And hopefully we'll do another one of these, recording live from Dundee. For anyone that missed the beginning, we are live today. We are so excited about it. Thank you to everybody that attended and that is watching this. And we really hope you've enjoyed today's Reach Out Recall webinar. Certainly we have, and I'm going to thank the Dystonia UK team who are in the background, who you don't see on camera because they've been working really hard in the background. So thank you, Tom. Thank you, everybody. I hope you have a lovely, lovely warm summer's evening, and we will say good night.
Okay, thanks.
Thank you.